Hello friends, today I'm going to speak on the topic pulpotomy. Coming to the definition of pulpotomy can be defined as removal of the coronal portion of the dental pulp followed by placement of a medicament or dressing that will promote healing and preserve the vitality of the tooth. This definition was given by Finn in the year 1985. Coming to the indications of pulpotomy, a cariously exposed primary tooth whose retention is more advantageous than its extraction, a vital tooth with a healthy periodontium, pain, if at all present, it is not spontaneous and it is a reversible type of pulpitis. That is, if you remove the stimulus, the pain goes away. Such a tooth is indicated. Tooth which is restorable, tooth with two-thirds of its root length is present. Hemorrhage from the amputation site is pale red and can easily be controlled. In a mixed dentition stage, primary tooth is preferable to a space maintainer. These are the indications for doing pulpotomy. So if you look at this radiograph, we can see that there is extensive carious involvement approximating the pulp. There are no periapical changes seen, and there is two-thirds of the root length is visible, and there is no interradicular bone loss. Such a tooth can be considered ideal for pulpotomy. So coming to the contraindications, when there's evidence of internal resorption, presence of interradicular bone loss, abscesses, fistula is present, periapical changes are there, then there is radiographic signs of calcific changes, caries penetrating the floor of the pulp chamber, and tooth that are close to natural exfoliation are contraindicated for pulpotomy. So coming to the classification of pulpotomy, it is classified into vital pulpotomy techniques and non-vital pulpotomy techniques. Under vital pulpotomy techniques, there is devitalization, preservation, and regeneration. So under devitalization comes single sitting and two sitting. In single sitting, the materials used are formocresol, electrosurgery, and lasers. Whereas in two sittings, the materials used are GC trio paste, S-Lix formaldehyde, paraform devitalizing paste. The materials used for preservation include glutaraldehyde, ferric sulfate. MTA doesn't come under preservation, although it is mentioned wrongly in textbooks. MTA actually comes under regeneration along with bone morphogenic proteins. And the materials used for non-vital pulpotomy include beechwood cresol and formocresol. So they are broadly classified into vital pulpotomy techniques and non-vital pulpotomy techniques. Under vital pulpotomy techniques, there's devitalization, preservation, and regeneration. Coming to the treatment objectives, first objective is to amputate the infected coronal pulp. And after amputation, we have to neutralize any residual infectious processes, then preserve the vitality of the radicular pulp, avoid breakdown of the periapical region, treat the remaining pulp with a medicament, and avoid dystrophic pulpal changes. These are the objectives of pulpotomy. So coming to the first classification, devitalization, single sitting. Formocresol pulpotomy. This single sitting technique is also known as formocresol pulpotomy technique. It was first advocated by Sweet in 1930. So the formocresol solution is composed of 19% formaldehyde, 35% cresol, and 15% glycerin. So as the name suggests, formo and cresol is composed of 19% formaldehyde and cresol, 35%, glycerin is the vehicle, 15%. Now what is Buckley's solution? Buckley's solution is 1:5 concentration of the formocresol solution. Now how do you prepare the Buckley solution? First, thoroughly mix 3 parts of glycerin with 1 part of water, distilled water. Then add these 4 parts to 1 part of the Buckley solution to form the formocresol to form the Buckley solution. So coming to the mechanism of action, formocresol can prevent tissue autolysis by bonding to the protein. But this is a reversible process without any change in the basic structure of the proteins. So coming to the techniques for pulpotomy of the primary teeth. First, anesthesia of the tooth and the tissue is required. Then isolate the tooth with the rubber dam. evacuate or excavate all the caries, remove the dentinal roof of the pulp chamber, then remove the coronal pulp tissue with a slow speed round burr. Number 6 or number 8 round burr or a sharp spoon excavator is advised. Then once you have removed that pulp tissue, we have to achieve hemostasis with moist cotton pellets under pressure. Then apply the diluted formocrosol to the pulp on a cotton pellet for 3 to 5 minutes. Then apply pressure on the pellet. The pulp chamber is then dried with the new cotton pellets. Place a thick paste of the medicament, that is zinc oxide usual, in contact with the pulp tissue. Then stainless steel crowns can be placed. So first what we do is that we excavate the caries, they remove the roof of the pulp chamber, then we use number 6 or number 8 round bar to ampute the coronal portion of the pulp tissue and the radicular tissue is left there. Then we try to achieve hemostasis. After achieving hemostasis, we use a cotton pellet moistened with formol solution, place it for 3 to 5 minutes and then remove it. Then we place the zinc oxide usual medicament on top of it, and finally the stainless steel crown is bonded using zinc phosphate cement. Coming to devitalization pulpotomy two-stage technique. This two-stage procedure involves the use of paraformaldehyde to fix the entire coronal and the radicular pulp tissue. The medicaments used have a devitalizing, mummifying, and bactericidal action. So when do we do a two-stage pulpotomy? By devitalization. When there is profuse bleeding, difficulty in controlling the bleeding, there is spontaneous pain is present, slight purulent discharge, and there is thickened pedial space. So that's when we do a two-stage step. The contraindications for the two-step devitalization technique is when it is non-restorable, necrotic, and the tooth is soon to be exfoliated. So the medicaments used for two-stage technique are the GC triopaste, which is composed of tricrosol, cresol, glycerin, paraformaldehyde, and zinc oxide. Then there is a S-Lix paraformaldehyde formula and the paraform devitalizing paste. The S-Lix paraformaldehyde formula consists of paraformaldehyde, similar to the paraform devitalizing paste that also has paraformaldehyde. The analgesic agent is the procaine base in S-Lix paste, whereas it is lignocaine in paraform paste. Then there is powdered asbestos in S-Lix paste and propylene glycol in paraform. Instead of they use petroleum jelly in S-Lix paraformaldehyde formula, whereas in paraform paste they use carbovax, and they both have carmine as the coloring agent. So coming to the two-step in detail, at the first appointment, isolation of the affected tooth with rubber dam is done. We prepare the cavity, excavate the caries, and once excavation leads to pulpal exposure, we enlarge the remaining cavity with a round burr. Then a cotton pellet filled with paraformaldehyde is placed on the site of exposure for 1 to 2 weeks. The advantage is that the formaldehyde gas liberated by the paraformaldehyde will penetrate through the coronal and radicular pulp tissue and fix the tissue. On the second appointment after 2 weeks, local anesthesia has to be given. The roof of the pulp chamber is removed and cleaned with saline and then dried with cotton pellet. And the pulp chamber, after amputation of the removal of the coronal pulp tissue, it is then filled with the antiseptic paste and the tooth is restored and a stainless steel crown is placed. Coming to the partial pulpotomy. The partial pulpotomy for traumatic exposures is a procedure in which the inflamed pulp tissue beneath the site of exposure is removed 1 to 3 mm to the extent that the deeper, healthier pulp tissue is reached. So it is indicated for a vital, traumatically exposed young permanent tooth, especially the one in which the root formation is not complete. We have to preserve the radical pulp tissue so that the root formation will take place. So the materials used are the calcium hydroxide and MTA. Coming to non-vital pulpotomy, ideally a non-vital tooth should be treated by pulpectomy or root canal filling. But sometimes it is difficult to do these procedures, especially when the canals are non-negotiable and the tooth is mobile and there is abscess. So in such cases, the two-stage pulpotomy technique is advocated. So this criteria for Doing this two-stage technique, non-vital pulpotomy is when there's history of spontaneous pain, there is swelling, redness of the mucosa, the tooth is mobile, and there is tenderness to percussion, and there is a radiographic evidence of root resorption. So coming to the technique, on the first appointment, the necrotic pulp is removed. The pulp chamber is then irrigated with saline and dried with a cotton pellet. The radicular pulp is treated with beechwood cresol dipped in cotton pellet. They seal the cavity with a temporary cement and wait for 1 to 2 weeks. On the second appointment, isolate the tooth, remove the temporary dressing and pellet containing beechwood cresol. If any signs or symptoms persist, then repeat the procedure or go for extraction. If no symptoms is present, the chamber is filled with antiseptic paste like zinc oxygenol, then it can be restored with a stainless steel crown. Coming to the electrosurgical pulpotomy, it is proposed by Mack and Dean in the 1993. It is a non-pharmacological technique and is a non-chemical devitalization. Here, electrocautery, carbonized and heat denatures the pulp and bacterial contamination. So after amputation of the coronal pulp, the pulp stems are cauterized through this method. After completion, the pulp chamber is filled with zinc oxide eugenol and the tooth is then restored with a stainless steel crown. The disadvantage is that the contaminated pulp does not permit the passage of current through the radicular pulp tissue. So the radicular pulp inflammation may not be completely resolved. So that is a disadvantage of that. Coming to laser pulpotomy, it is also a non-pharmacologic hemostatic technique. Certain studies done by Jenfu Liu, they found out that NDYAG lasers had in primary tooth had 100% success rate with no signs or symptoms. So coming to the preservation part, chemicals which induce minimal insult to the pulp tissue are used. Those chemicals include glutaldehyde and ferric sulfate. The advantage of using glutaldehyde is that they have superior fixation, their diffusibility is limited, excellent antimicrobial action, causes less necrosis of the pulp tissue. Whereas ferric sulfate is used because it has astringent activity that is reduce the bleeding, forms a ferric ion protein complex that occludes the capillaries, less inflammation than formocrosol, 92% radiographic success rate and 100% clinical success rate is observed. Root resorption is not accelerated. Internal resorption similar to formocrosol. So coming to the last procedure, which is regeneration, an ideal pulpotomy tech treatment should leave the radicular pulp tissue vital, healthy, and completely enclosed within an odontoblastic dentine-like chamber. So this is achieved with the help of bone morphogenic proteins and MT. So what these materials do is that they are capable of inducing differentiation and proliferation of the mesenchymal cells into odontoblastic cells that are capable of forming dentin. So this concludes my presentation. Thank you.